This is our small department. We have 6 consultants and now 8 residents. And now I request my resident to present the case.
Thank you, sir. Good morning, respected senior faculty, my colleagues and my friends. Today we'll be presenting a case of 18-year-old female with a facial deformity. So I would like to ask the house what deformities you can appreciate in these photographs. Can anyone tell? Yes? Yes, fine. Anyone else? Yes, very good. So these are the broad findings we can see. Now we'll move on to the case. So 18-year-old unmarried female, a college student, resident of Bharatpur, Rajasthan, comes with a complaint of recurrent nasal discharge since her childhood, difficulty in chewing since 12 to 13 years, and deformity of lower part of midface since 12 to 13 years. So the patient had frequent nasal discharge since her childhood, which was watery in nature and was not associated with fever or any ear discharge. There was difficulty in chewing since 12 to 13 years. Patient was able to bite the food but was not able to chew the food properly. So, and there is a deformity of lower part of midface and which was progressive since childhood. So, the patient was born with cleft lip and palate. For the cleft lip, she was operated at the age of 1.5 years, and for cleft palate, she was operated at the age of 2.5 years. Both surgeries were uneventful. In the perinatal history, the patient was full-term normal vaginal delivery, and the mother had no history of any addiction or any drug intake during her pregnancy, apart from drugs supplied by the government. In the personal history, the patient achieved her milestone as per her age, normal bladder and bowel habits, normal sleep and appetite, with no history of any addiction present. The immunization history, the patient is immunized as per her age. There was no significant similar history or history of cleft present in the family. So, 18-year-old female, unmarried females, whose operated case of cleft lip at the age of 1.5 years, for cleft palate operated at the age of 2.5 years, with deformed lower part of midface, frequent nasal discharge and difficulty in chewing, with no history of cleft in family, uneventful perinatal period, no nasal twang or any ear discharge present. On general physical examination, the patient was conscious, cooperative, moderately built, fairly nourished, with vital stables, no evidence of pallar, cyanosis, icterus, clubbing edema. The BMI was 18.8. So, on the local examination, like previously discussed on the first slide, what are the findings we can see? First is the maxillary retrusion, as you can see over here. The upper lip depression and the previous operative scar over the upper lip. In the intraoral examination, on a mouth closure, the upper teeth lies posterior to the lower teeth with gap between the premolar and the molar of the upper and the lower jaw. There is a type 3 occlusion present. The upper arch is collapsed and the lower arch is wider than the upper arch. There is a scarring of palate. The movement of the soft palate is normal. The secondary deformities which were present was nasal deformity with slight deviation toward the left side, depressed nasal tip, and the LR asymmetry. There is a minimal scar visible over the upper lip. The upper lip and the upper jaw are retruded and collapsed. There is a hypertrophy of nasal terminates on nasal examination. The other systemic examination of cardiovascular system, respiratory, genitourinary and gastrointestinal and musculoskeletal system were normal. So, with the history and examination, we proceeded with the radiological investigations. So, for that, I would like to call Dr. Neha from the Department of Radiodiagnosis.
Good evening, scientifically, how do you say that it is maxillary retrusion, not mandibular protrusion?
Yes, sir. So they are basically based on cephalographic tracings, and which we can see the angles of the faces.
So you should have described.
So I will be describing it later, sir.
Good morning, respected faculty, teachers, and my dear colleagues. Myself, Dr. Neha, first year PG resident, Department of Radio Diagnosis. I am presenting here the CT findings of this case. Here in this axial view, you can see there is a defect in the right side of the maxillary bone, which is extending up to the alveolar process. And on the coronal view, you can see that there is a through this defect there is a communication between oral cavity and the nasal cavity. In this axial and sagittal view, there is no obvious deformity in the upper lip of this patient is seen. These are the 3D reconstructed images of the face, in which in front view you can see there is a defect in the alveolar process of the maxilla, which is extending till the nasal cavity. And on lateral view you can see there is retrusion of the maxilla. Here you can see multiple opacities are seen in the right side of the nasal cavity, suggestive of rhinoliths, and these are likely due to chronic secretions. Here we can see mucosal thickening of the ethmoidal air cells, suggestive of ethmoidal sinusitis. Now I invite Dr. Tushar for the further continuation. Thank you.
Thank you, Dr. Neha. So as we have completed our radiological investigation, we moved with routine laboratory investigations which were within the normal limits. The CT findings suggested of bony defects in the right side of the hard palate, extending up to the alveolar margin between the right upper lateral incisor and canine, with communication with the right nasal cavity and the oral cavity, with multiple calcific densities seen over the right nasal cavity carrying rhinolith. The chest X-ray were normal. So with all this history, examination and investigations, we come to the diagnosis of maxillary retrusion with the type 3 malocclusion in an operated case of cleft lip and cleft palate. So as this is a secondary deformity after the cleft lip and palate surgery, so we should understand the basic embryology and the anatomy of the cleft lip and palate. For that, I would like to call Dr. Rishika from the Department of Anatomy.
Thank you, Dr. Tushar. Good morning, everyone. So, as the case is being suggestive of cleft lip and cleft palate, let us study the embryology behind it. So, facial development starts at the 4th week of intrauterine life. So, here, this is the pictorial representation of embryo at 24 days of intrauterine life. This opening seen here is known as stomodium, which is the primitive oral cavity. So, there are 5 main processes which are responsible for the development of lip and palate that bounds the stomodium. The stomodium is bounded cranially by the unpaired frontonasal process, laterally by the paired maxillary process, and caudally by the paired mandibular process. So, the lower lip and lower palate are the first formed organ in the face. That is why at the 4th week itself, the two mandibular processes fuse at the midline to form the lower lip and lower jaw. Now, what happens is there is the local thickening in the frontonasal prominence, which is known as nasal placodes. Nasal placodes then later shows a pit which are known as nasal pits. Now around the nasal pits there is mesodermal thickenings which distinguish into two processes, namely lateral nasal process and medial nasal processes. The lateral nasal process then fuses with the lateral part of the maxillary process to form the lateral part of upper lip and the cheek, obliterating the nasolacrimal groove after the formation of nasolacrimal duct. Then what happens is, as the maxillary processes start expanding, the medial nasal process get closer to each other in the midline. At the 48 days, the medial nasal process fuses with its counterpart and the maxillary process to form the intermaxillary segment, philtrum, and the medial part of the upper lip. So this is how the lip formation takes place. Now talking about the development of palate, palatogenesis takes place within 6 to 12 weeks of intrauterine life. So we have two types of palate, namely primary or primitive palate and secondary or definitive palate. So as we have discussed earlier that the primary palate forms from the intermaxillary segment that is formed by the fusion of two median nasal processes at the 6th week of intrauterine life, and the definitive palate is formed by the palatal process of maxillary prominences that grow in the horizontal direction and fuse in the midline. So all this fusion of primitive and definitive palate takes place in a Y-shaped manner, and it takes place within 9 to 12 weeks of intrauterine life. So this is how lip and palate develop. So any non-fusion of these 5 processes can lead to a defect which is known as cleft. So the case was of bilateral complete cleft lip and cleft palate. So the bilateral cleft lip was due to the non-fusion of maxillary process with the median nasal process on both the sides, and the cleft palate was due to the non-fusion of palatine process. Thank you.
Hello.
Good morning, sir.
Can you tell us the role of genetics here in cleft lip and cleft palate?
Sir,
Is the genetics responsible,
yes, sir.
and in what way it is responsible?
Sir, if one parent is affected with cleft lip and cleft palate, then there is a prevalence of 4% chances that the offspring will suffer from it, and if both the parents suffer, then 50% there are prevalence that the child will be suffering from cleft lip and cleft palate.
Any from the department of plastic surgery? Residents or consultants? Any role of consanguinity? Marriages?
I am unaware about it.
So in case, if both the parents are suffering from cleft, there are 50% chances that patient is going to have, child is going to have cleft. People have tried their best, lot of research is going on. Smile Train is also doing lot of research, but there is no definitive gene has been found, because this variation is so much. Like in developing countries, it is one patient in 500. There are other less developed of one patient in developed countries, one patient in 1,000. Then other in few countries is 1 in 700, and in few places 1 in 600. In India it is 1 in 700 cases. And in our observation, from the affluent class, if we see, there are very few cases of the cleft come, but only from village and rural class, there are a lot of patients, they come. At present in India, there are 5,000 cases which are still pending to get operated. And if one parent has a cleft, there are 4% chances, and if there is they already have one parent and one child who has already had cleft, there are 17% chances that the next child is likely to get cleft. So there are definite relationship, but definitely genetic relation had not been established.
What about the role of folic acid?
Folic acid has a great role. All the protein diet, folic acid, iron, a healthy diet is most important.
I think as an obstetrician, even if you take healthy diet, you require extra folic acid during pregnancy. And folic acid has been associated with lot of developmental defects, not only congenital defect, but definitely genetic origin is there.
But the CHT4 gene which is there, sir, which is maximum responsible for the Charge syndrome, which is the most commonly implicated gene as far as the cleft is concerned. Apart from that, there are CBT genes and SATB4 gene. These genes have been genetically linked to the formation of cleft palate.
When you show a diagram from a book, you should see what is the text size. Now, I can read it, but I'm sure people sitting in the last row cannot. So what you need to do is you need to enlarge, number one, and split it into 2 or 3. Number 2, whenever you are explaining a image, you should always use the cursor.
So now we move on to the aims of the management. So what are the aims for the management of this patient? First is to improve the function, better occlusion, the better airway patency, to improve the aesthetic of the patient and make the face more symmetrical. So for that we need a surgical planning. So what should be the planning? So we proceeded with two things. One is cephalographic tracing and another is dental model. So this is a cephalographic tracing. As we can see, it's a cephalogram of the face. So as pointed, this is S stands for sella, N stands for nasion, and A stands for subspinal area, which is the maximum point of concavity over the maxilla. So this angle normally is 82 degree plus minus 2 degrees. In our patient, it was 76 degrees. And the second angle is SNB angle, which is sella, nasion, and supramental, which is normal, which was 81 degree in this patient. And the cephalographic tracing is required for the amount of advancement we required. The second is dental model. We would like to thank to the prosthodontic departments for helping us in making the dental model for this patient. So the dental model helps in deciding the occlusion. So as we can see in this picture, it's a lateral view where we can see there is a posterior open bite in the dental model and there is a malalignment, which is a malocclusion type 3. But after correction, we can see it is now aligned. So we had a defect of around, we needed the advancement of around 7 mm in this patient. So as I described what, type 3 malocclusion, first we should know what is a normal occlusion, that is a type 1 occlusion. So it is an alignment of mesiobuccal cusp of the first maxillary molar over the buccal groove of first mandibular molar. And this is a type 3 where there is a mesial movement of the maxillary molar, and this was present in our patient. So we moved on with the surgical option. So first is distraction osteogenesis. It is the advantages are it has got better stability, lower relapse rates. With the disadvantage of it's a very cumbersome technique. It's very painful for the patient. It takes more time. There are chances of implant failure, and the patient patient requires compliance, and there is a prolonged follow-up. The second option is the osteotomy, with the advantages of that the bone movement can be done in a multiple direction. It's a single step stage surgery. It is well tolerated and it is superior in compliance and has a less follow-up. But the disadvantage is it has more rates of relapse if the advancement is more than 10 mm. So we had given both the option to the patient, and the patient opted for maxillary osteotomy with the advancement, that is Leaford type 1. So before we move forward for the surgical steps, I would like to invite Dr. Pooja from the Department of Anesthesia to explain the anesthetic workup.
Good morning everyone. I am Dr. Pooja Nigam, third year anesthesia resident, and I will be discussing about the anesthetic management of this case. So an 18-year female patient was referred to us with maxillary retrusion and a past surgical history of cleft lip and palate repair. So a thorough airway examination was done, and her airway assessment was suggestive of adequate 3-finger mouth opening, class 1 lip bite test, adequate jaw and neck movement, and Malampati grade 2. Though her airway examination seemed to be normal, but she was an anticipated case of difficult airway due to mid-face retrusion, prominent upper incisors, overcrowding of teeth, malalignment, and distorted anatomy. Now I would like to ask my fellow colleagues, what are the syndromes which are associated with abnormal facial features? Yes. Pierre-Robin syndrome, Apert syndrome. So as mentioned, the most common being Treacher-Collins syndrome, Pierre-Robin syndrome, Apert syndrome, Down syndrome, and DiGeorge syndrome. So to rule out these congenital conditions and associated cardiac, renal, or gut anomalies, we proceeded with a USG whole abdomen and echocardiography, which were normal. Coming to the airway, so the first and the most crucial step is to have a secure airway. And that becomes even more important in this case because This is an intraoral surgery, and that will be having a shared airway with the surgeon. So there were certain anesthetic challenges that we faced while securing the airway. The first one being difficult bag and mask ventilation. So this is a patient who has maxillary retrusion. So when we kept a face mask over the nose and the mouth of the patient, there was some amount of air leak which was in and around the mask. And to overcome that, we used a fold of gauze piece which was kept just below the mask so as to have a tight seal. The second is difficult laryngoscopy due to the prominent upper incisors and crowding of teeth. Difficult intubation due to malalignment and distorted anatomy, and as this was an intraoral surgery, therefore we proceeded for a Megels-guided nasal intubation, which was done with the help of a flexometallic endotracheal tube. Intraoperatively, head and neck surgeries are more prone to blood loss because this is a very vascular area. So, hemodynamic instability and blood loss was already anticipated. And for this, aggressive hemodynamic monitoring was done with the help of invasive blood pressure and urine output monitoring. And in case of excessive blood loss, blood was already arranged. The second goal was to provide hypotensive anesthesia. Now this is done not only to reduce the amount of blood loss during the procedure, but also to provide a clear surgical field. So hypotensive anesthesia is when the patient's baseline mean arterial pressure is reduced by 30% or to 50 to 60 millimeter of mercury in a normotensive patient. Now this can be done with the help of non-pharmacological or pharmacological methods. In non-pharmacological methods, we elevate the head end of the patient to 10 to 15 degree so as to drain the blood in the surgical field into the central system. The second is use of pharmacological agents such as alpha-2 agonist, that is dexmedetomidine, which is commonly used in our OT setup. So, because of the combined efforts, the surgical procedure was uneventful with the duration of surgery being 2 hours and a total blood loss of 200 ml. Lastly, to extubation. Generally in all intraoral and nasal surgeries, the surgeon places an oral throat pack in the oral cavity, which has to be removed prior to extubation, or else it will cause airway obstruction. The second is awake emergence. That is to remove the endotracheal tube or to extubate the patient only after they gain their airway reflexes, especially the cuff reflex. This is done so that the patient post-extubation does not aspirate any amount of secretion or blood which is present in the oral cavity. Other complications could be post-operative bleeding and emergency re-intubation. Now I would like to call Dr. Tushar for further proceeding with the case.
Thank you, Dr. Pooja. So now we move forward with the surgical steps. So first of all, we give incision 5 to 7 mm above the mucogingival junction with undermining of the mucoperiosteum, and then we'll move to separation of the septum from the vomer. Then we'll proceed with osteotomy done with the reciprocating saw. Then completion of osteotomy from the posterior maxillary sinus with the using burr, and then we'll separate the pterygomaxilla. Pterygomaxillary disinfection will be done by using the curved osteotome. So these are the images with the fixation of titanium plates, mini plates, and these are the original picture of the patient with intermaxillary fixation done and the mini plate fixation. So here's a small video, 8 to 9 second video of osteotomy being done. This is the maxillary osteotomy. Osteotomy separation. And this is the second video of maxillary disinfection by using the rose forceps. So, in our patient, the post-operative course, on the day 0, it was the procedure was uneventful and the patient was extubated in the OT. On the day 1, we allowed the oral liquids to the patient. On the day 2, the nasal pack was removed. On the day 3, dynamic intermaxillary fixation was done with the rubber bands. On the day 4, the patient was discharged. So these are the post-operative X-rays. And here's the comparison cephalogram. So this is a preoperative cephalogram in which the SNA angle was 76 degrees, and the postoperatively now it has increased to angle of 84 degrees. So these are the pictures of patient preoperatively, postoperative on the day 4 and on the second week follow-up. As we can see, there is a maxillary advancement. So, what is the incidence of cleft lip and palate? In the developing country, it is 1:700 live birth, and in the developed country, it is 1:1000 live birth. So, every year, 35,000 children are born with cleft lip and palate deformity in India. If the both parents are having cleft, the probability of having cleft is 50%. If one parent having cleft, there are probability of 4%, and one sibling is having cleft, again probability of having 4%. So what should be the treatment protocol when the child is born with cleft lip and palate deformity? The cleft lip should be repaired ideally at the age of 3 to 6 months. Cleft palate should be repaired at the age of 9 to 12 months. The secondary alveolar deformity should be covered with bone grafting at the age of 7 years to 10 years, with orthognathic surgeries to be done at the age of 16 to 18 years. The corrective rhinoplasty, which is optional for patient, should be done again at the age of 16 to 18 years and above. So the total number of cases we operated in the last year was 26. Cleft lip patients was 4, cleft palate were 8, and the secondary deformities with secondary deformities 14 patients were there. So we get more complicated and failed cases being operated in other hospitals, and they come to our Mahatma Gandhi hospital. So what are the complications related to the osteotomy which were not present in our patient? First is the bleeding, implant failure, excessive bleeding, respiratory problems, infection on the bone graft exposure, osteomyelitis, relapse, and the velopharyngeal insufficiencies. Now I would like to call Dr. G.S. Kalra sir to summarize.
So I have a question. Can you diagnose it in utero, and
Yes,
at
sir.
what age?
This can be diagnosed by ultrasound. Usually, when you do the ultrasound at around 16 weeks, it can be easily diagnosed. And not only diagnosed, it can be treated. It can be, yes, in vitro surgery is possible. When a child is born with a cleft, whole of the family, feels very disturbed. And to get away from this, at few centers in US and Europe, they do in vitro, during, at the age of around between 6 months, when it is safe, the patient will not abort, and the cleft is established, they open up, that's like cesarean section, take the child out with the blood supply intact, spot attached, they operate and then put it back. And beauty is, this surgery is scarless. Whatever surgery is done during this period, there is no scar. Like whenever, if you do after the child is born, there will always be a scar. But in the uterus, there is no scar.
But I have a question. You said that the appropriate age to repair cleft lip is after 3 months.
Yes.
If that is the appropriate age, then why do in utero? Then why not immediately after birth?
It can be done after birth. It can be done immediately after birth, but then it will leave scar. Usually, why we do at 3 months or 4 months, basically, initial 48 hours, patient's immune status is very good. After 48 hours, child's immune status, infant's immune status starts going down. So unless there is an emergency, we do not operate. Gradually, when the weight increases, we operate between 3 months to 6 months, depending upon the weight and all the criteria. That hemoglobin is okay, counts are okay, everything is fine. And the most important part is development of lungs. Initially, lungs are not adequately developed. It is only done for emergency. By 3 months, child's lung, they are developed quite well.
Otherwise also, just hold on. Development of the fetal medicine and fetal surgery is a very advanced sort of things, and very few centers in our country are performing that. Lot of experience is required. Maybe in next decade we should be able to perform these procedures here.
In fact, I will request Professor Shankar, because he has such an extensive experience in the pregnancy and all, that if we can provide a facility, we can easily do repair.
So, sir, it is already in our mind to develop the department of fetal medicine and medical genetics.
Then, as most of the people are poor, there was a Smile 10, which was basically that organization. It was developed basically by Charles Wang, who was an American, Chinese American, whose daughter had a cleft. And then he found that there's so much of problems. I was associated with the Smile 10 from 2009 to 2017, and they had given me an award of being, for the good association. So, yesterday I again talked to the regional director of the Asia Pacific, Dr. Mamta Karol, about starting the Smile 10 program in our institution. And she said very positively, she said, and I told her that you come to our hospital and see the hospital, and then you decide. Then she will, I will surely send some, they will see. I told her that we have a very good infrastructure, and we have very good outreach program, which is most important. Because if we need an outreach program so that we can collect more patients and help the people. Because these people, they come late. They don't know when they are to be operated. If they are operated timely, their dentition is good. If they are operated before 1 year, their speech is excellent. But if they are operated at 2.5 years or 3 years, they will always have a nasal speech. That is the problem. That is the most important. And the take-home message is that if all these surgeries can be done without any difficulty, and infrastructures, we have all type of infrastructures here, and we need a lot of outreach program to cater these patients for the. And we need a lot of proper counseling and awareness to the society that this is not something like, as people think, it has, God has given some curse and they have to deal with it. It is not like this. Everything can be done and patient can live a normal life. Thank you. And we acknowledge number one, patient's relatives, then our hospital management who has helped. We thank very much the people who had done a lot of help to review this CPR and collaboration of all the departments. Thank you, sir. And our medical director who had been with me, he had been very active in this, a good presentation of the CCR.